and thank you, Chairman and colleagues. It's a great pleasure to be here this evening. And of course, gluten and functional gastrointestinal disorders, is it worth the challenge? It's a very difficult question because we are moved into a very difficult scenario because, as you know, functional gastrointestinal disorder is characterized by symptoms not attributable to anatomic or serological or biochemical defects. So it remains an exclusion diagnosis. Of course, we have their own free criteria that we can adopt to classify these kind of syndromes, and has been identified 18 types of functional disorders. Anyway, IBS and dyspepsia are the most common, but frequently it's difficult to split this kind of patients in types or another one, because frequently there are overlaps between patients, and the main problem is there in outpatient service, especially in gastroenterology. These patients are a lot. Up to 30% of patients could have a functional disorder, and probably, as we know, in a higher prevalence is in adult females. Of course, how we can diagnose a functional disorder? Of course, clinical suspicion about, above all, epidemiology and symptoms are the main factor, but we have no biomarkers still, no alteration. We can, in histology or serology or endoscopy or radiology, cannot help us to make the diagnosis, so it remains an exclusion of the other diagnosis. Different factors collaborate in the development of this kind of syndromes, above all motility dysfunction or visceral hypersensitivity, low-grade inflammation, and central perception or psychological component cooperate in the development of symptoms, and also therapy, and that's why therapies we can use are so different. Behavioral therapies or laxatives, or of course it depends of the type of functional disorder, antidepressants or psychological therapies. That especially means that we still do not have an effective drug for this kind of patients. And above all, another problem is that we know that up to 50% of placebo effect, as we know from the trial, could affect this kind of patients. So what we are facing now is that the connection of this kind of syndromes with food, and is so complicated, as we have seen with a slides from Carlo a few minutes ago. And if we speak about gluten, we see that there is the demonstration that gluten can be a factor of the symptoms of these patients, as has been demonstrated in the 80s from this paper. After that, there is this cohort of patients been forgotten for a lot of years until the 2000, when the gluten-related disorder has been reclassified. And of course, this kind of patient having a benefit from the gluten-free diet has been categorized as non-celiac patients affected by non-celiac gluten sensitivity, which is actually defined as a syndrome characterized by gastrointestinal but also extraintestinal symptoms improving after gluten withdrawal. Of course, gluten is the major suspect as a trigger, but other factors could be involved, as the amylase trypsin inhibitor or the FODMAP. However, conflicting data are still present in literature. And also for the non-celiac gluten sensitivity, we have no biomarkers which can help us to make the diagnosis. As we see a few minutes ago, maybe the anti-gliadin antibody, IgG type, could be used, but further data are needed to demonstrate it. What we are facing now in our room as gastroenterological specialists in our outpatient service, that in the very large group of functional patients, there is a smaller one, but very considerable, of patients responding to a gluten-free diet without a celiac disease. How we can define this kind of group as non-CD gluten-free diet responders? What is this kind? Is it a placebo effect? Or we have the choice, or we have to find a weapon to differentiate the gluten-free diet responders from the patients affected by non-celiac gluten sensitivity. what we can use with no biomarkers. Probably the only way to go out from this trouble actually nowadays is to make a challenge, a double-blind challenge with gluten, to split these patients among the patients responding to a gluten-free diet. Of course, that's major questions are about the challenge. What challenge, wheat or gluten? That's an important question. We can use gluten, but when people avoid gluten, avoid a lot of other molecules, as we have seen, also for example, the amylase trypsin inhibitor, but also other components present in wheat. How much to challenge? Milligrams, grams? That's a major question. It depends a lot from the results of the challenge. How long? Days, week, or months? It's the best choice for the challenge. Which vehicle to use? Muffins, capsules, or bars? How to measure the response? We have seen that this kind of patient have both the gastrointestinal and extraintestinal symptoms. We can use the visual analogic scales or other kind of scores. And which are our expectation? What we are looking for? We are looking for a complete resolution of the symptoms of our patients after a period of gluten-free diet, or it's enough to have a partial response in this kind of patient. That's all very important question that we plan a challenge should be answered. And now let's see what the literature have been published to answer to this question. These are the main trials using challenging gluten. The first is very famous, is the trial in 2011 by Bizikieski in the American Journal of Gastroenterology. This author included the patients affected by IBS following their own free criteria, and they tried a double-blind placebo-controlled challenging 16 grams of gluten. It's a very, very high dose, and using muffins as vehicle. They used vast visual analogic scale to measure the symptoms. What they found an increase of the symptoms while taking muffins with gluten, mainly gastrointestinal symptoms. And what you can see at the symptoms are very quick after the ingestion of gluten. They take 1 week long, this kind of challenge, but the symptoms are very quick after the first day and the second day, and after that there is a steady state. Another trial by Antonio Carroccio in 2012, challenging in a double-blind placebo-controlled challenge with crossover, this time challenging patients affected by IBS symptoms following their own 2 criteria. They evaluated the symptoms using visual analogic scale, and what they use is a 3 centimeter cutoff to define patients positive to the challenge or negative to the challenge. They found that out of 900 patients with IBS, 276 were positive to wheat, not to gluten. They challenged wheat using 13 grams in capsules, and the main problem when you use capsule in this kind of challenge is the number of capsules that you need. They use 12 capsules per day. Another trial is the trial from the group of Mayo Clinic. This is a trial, the third one, published in Gastroenterology in 2013. They included patients affected by IBS diarrhea type. It's not really a clinical or a trial evaluating the clinical of the patient, but it's the pathophysiology of the patient. In fact, they randomized challenging patient with a gluten-containing or a gluten-free diet, and they evaluated the bowel movements, the small bowel, and the colonic permeability and the tight junction. What they found that the patients taking a gluten-containing diet have an increase of movements, an increase of small bowel permeability, and an alteration in the proteins only, especially in the tight junction alteration. The last one is a trial from the group of Pavia, from Di Sabatino, recently published in Clinical Gastroenterology and Hepatology. They enrolled patients with unspecific gastrointestinal symptoms, and they use a double-blind placebo-controlled challenge with crossover. They challenge gluten, it's 4.3 grams. They use as vehicle capsule, and it means 10 capsules per day. They evaluated VAS, visual analogic scales, always to measure the symptoms. And they found, similar to the first trial by the Australian group, that there is an increase of or a worsening of the symptoms while taking gluten blindly, both intestinal and also extraintestinal symptoms, especially the foggy mind, depression, and the after symptoms, stomatitis in her mouth. What can be noted by this trial that they use all different types of vehicles and different types of dose of gluten. That's a major problem if we try to compare these kind of trials. Another trial that we recently presented and will be presented on Tuesday, we use from my group, we used to challenge gluten in a double-blind placebo control with placebo, 5.6 grams per day, it means 7 capsules per day. We used visual analogic scales to measure the symptoms, and we used a cutoff of 3 centimeters, similar to the Carlo study. Briefly, what we found, we enrolled the last year 100 patients, and 81 responded to the gluten-free diet and were randomized for the challenge, and 25 patients responded to the gluten challenge, were positive to the gluten challenge. So probably this kind of patient, and I suspect to be non-celiac gluten sensitive. Anyway, when you end your challenge, or if you use wheat or gluten or muffins or capsules, anyway you find this situation. You can have a double positive, a double negative, a gluten positive, and of course placebo negative, and the placebo positive and gluten negative. That's, of course, this kind of group, that's the positive or the patient with a high suspicion to be non-celiac gluten sensitive. This kind of group, it's quite a clinical problem because it's cutoff dependent. It depends on the cutoff that you're using to share this kind of group. If you change the cutoff, in fact, some patient could jump into this group. So it's very challenging problem for clinics. Of course, this third group is negative, and this last group with placebo positive or gluten negative is merely a statistical problem because probably if you have the same number of this patient and this one in this trial, probably something is not working in your design, statistically and clinically too. So what we are after, if you apply this kind of challenge to our huge group of GI functional patients, what we can find in another scenario, because we have the GI functional patient, we have the GFD gluten-free diet responder, about 60%, and inside this group of responders, there is a smaller one, but considerable, about 20% of patients with a high suspicion of non-celiac gluten sensitivity. So let's try to answer now to our initial question. What to challenge? Probably nowadays the best choice, however, remains gluten because it's the major suspect. How much? I think that between 5 and 10 grams could be reasonable dose of gluten. 16 is very high. You have to keep in mind that 6 grams of gluten are the content of 80 grams of pasta. So you have to keep in mind this kind of dose, and so 5 or 10 grams is a reasonable choice. How long? As we have seen before, I think that 7 days could be enough because the onset of the symptoms are very quick after gluten ingestions. Which vehicles? Probably capsule is the best because they maintain the blindness, but however in a real world probably bars is the best choice. What to use to measure the response? We have to keep in mind that we need a score evaluating both intestinal and extraintestinal symptoms, and probably visual analogic scales could be a choice. And what to use to the cutoff, because we need to share, as we said before, this patient positive, and what we expect if we are very happy if we have a complete response or a partial response is enough. So to conclude, the double-blind placebo-controlled challenge could be useful to discriminate patients with a very high suspicion of non-celiac gluten sensitivity among the large group of patients responding to a gluten-free diet. Of course, there is a need to create a standardized double-blind placebo-controlled challenge, and of course, the role of other than gluten molecules is still a very hot topic and a very open issue. Thank you for your attention.